Okay, wonderful. So hello to everybody here. Since due to the delay, we have started to work, and I will show you through the case. Maybe you can take the stent out and put the other one in. So maybe let us quickly bring you through the case.
Case pe le aao.
My colleague will introduce the case to you.
Yeah, greetings from Pant Postgraduate Institute. This is a 47-year-old male smoker who presented with class 3 angina with intermittent rest pain for last 2 months. His ECG was normal and ejection fraction was normal. Due to severe angina, angiogram was done which showed severe left main disease, extent and stenosis in the circumflex artery. The options were discussed with the patient and the patient was planned for PTCA of the left main coronary artery. We have Chris Naber from Germany to do this procedure.
Okay, maybe we can, did we see the angio already?
No.
Okay.
Show the angiogram.
We have seen the angiogram.
Okay, so what you see here is you see, let's say, not ostial but shaft left main. All the rest of the vessel is more or less fine. Let's go to the next image. There was nothing on the right. Here you see that the ostium is quite okay. One back, please. Yeah. Yeah, the ostium looks quite okay. There's a small bubble going down the LAD. And you can see that the ostium of the circumflex also looks very nice.
Yeah, it's
Next
very,
image,
very clear.
yeah. Here you see again, it's the shaft plus the ostium. Yeah, next please. I wired the vessel already. Why? Because I wanted to push out the left, the guiding catheter from the left main. The problem was that we are having a pressure dumping. We are using 7 French femoral here, and so that was a little bit big for the diseased vessel.
Chris,
Now, while we were waiting,
one question.
we wired the second vessel and put the balloon.
When will you use an IVUS in this case? Pre or only post?
Sorry, I could not hear you.
When will you use an IVUS?
IVUS.
Only post procedure or
Yeah. So,
pre?
We know that in distal left main disease, mostly ostium of the LAD or LCX is involved. And so I think PCI IVUS may be necessary.
okay. So my reasoning for not using an IVUS pre is that I believe we have no significant stenosis of the circumflex.
Angiographically.
So
just,
my technique that I would like to use is provisional stenting. And unless I have a severe pinching or the final stenosis of the circumflex, I would like to stick with the provisional approach.
Okay.
So IVUS will not change my strategy.
Okay, so strategy of provisional stenting.
So what you see,
Is all right.
There is one thing interesting because we discuss about use of imaging, etc., pre, pair, post. Concerning the size, when you look at the, can we see the angio again? Yeah. Simply, without IVUS, without CT, the LAD is 3.5 in proximal. The circumflex is between 3.5 angiographically and 3.5. So we can expect that the left main size will be at least 4.5 millimeter. No, without IVUS. So if we start at 4, you can say that it should be too small. Okay? This is simple and cheap. Go on.
exactly, Jean. I fully agree with what you just said. And I'm sorry, we are having a significant delay, so sometimes I might speak when you speak. So what we choose is, we believe even that it's bigger than 3.5, the proximal LAD. So what you will see is the result post balloon. We took a 3-0 balloon, but we are planning to take a 4-0 stent.
Next angiogram. Next angiogram. Next.
Next. So do we have? Yeah, this is post 3-0. It didn't do much, and now I have a 4-0 18 stent here.
This is an onyx stent.
I'm using the stent now in the LAO cranial in order to be good at the osteum. So let me first check here now with contrast where we are. Okay. Injection, please. So what do you think?
Maybe what we can do is to advance a little bit the guiding catheter to have less contrast in the aorta, just 1 millimeter.
Okay. Yep. Again. Better.
Yeah, and then it's difficult in this view.
Can you show the image?
Using another wire in the sinus, the left sinus, will that make it easier to position the stent?
Go to the LAO caudal.
What you can do also, it's maybe less LAO.
Sorry, I could not hear that.
Take the same cranial, but less LAO and test, and you will find the best view. Here it will be difficult in
Let's look again.
caudal.
Yeah. It's the caudal, I think. Now, okay, maybe we look in the AP cranial.
Yeah, it's better to maintain the cranial view, but you know, play from the LAO to the AP cranial. Yeah, you will find certainly the best view here, maybe.
Yeah, I think this is a good one.
Can we see it? We
So,
didn't see it.
injection now?
This one is better, yeah.
I think.
We cannot see the fluoro.
Okay, now, image. Yeah, I will do.
Okay,
Yes, it is well covered, the osteum.
it's difficult to see. We have a black screen.
You okay with that?
Yes.
Ah, okay.
Here is better.
What do you think?
I think it's not too bad. I will check in the maybe
For
a
me, it's
little
quite
bit
good.
more LAO, and without moving the
Yeah,
stent.
let's go a little bit
And
LAO.
if you have two
a
or
few
three,
degrees.
angio.
Iliocranial.
Yeah, and go down there. Okay, perfect. Now we do again. Angio.
Iliocranial.
I think we are okay.
We couldn't see it. Okay.
Ne.
We didn't see the angio.
I hope you can see it now. Okay, let me do again. Can we do again, please? They don't see it.
If not, you use in fluoroscopy, because when you are filming, we have a black screen. You can do
Yeah.
in fluoro.
Okay, I will show you the fluoro.
Yeah.
Fluoro, go. Inject, please. Inject, please.
Yeah, it's correct. Correct. Yeah.
Could you? Yeah, it's good. Can we go now to the caudal to see if we are distally okay? AP caudal. I will not move the stent. Go AP caudal. I'm fine.
Cranial.
So as you said, Dr. Matthew, one trick is to have a third wire floating into the
Injection.
aorta to
And
really
store fluoro.
identify the origin of the osteum.
Okay, yeah.
That can help as well. It's not that it's an osteal lesion, it's just a short left main.
Here, with the osteum disease-free, probably you can take a little more, it is not very critical that we miss the left main osteum or not. So it can be a little more
Right.
easier.
Here's not too bad.
Display is fine.
So I think we will put it here. Okay, go up with the stand.
So as you may have noticed, Dr. Naber just pulled the guide slightly to make sure he would not stent the tip of the guide at the time of balloon
10, 12,
inflation.
14. I think 14 is enough. 4 is bigger.
So what's
Okay,
the
here you
size?
see it's nicely expanded. We go down.
It's 4-0.
It's a 4-0 because
Okay.
we felt that the proximal LED is a little bit bigger.
Yeah.
I will pull it back.
You may want to
And
do
now
a balloon
push the
inflation more
guide further.
proximally to flare the stent, but okay. This is
Yeah,
fine
we want
too.
to do. We are planning now to go with the NC50 balloon anyway.
5.
So I will do it with this balloon. But I could have done it with the other balloon as well. You're right.
Do you still have
So
pressure
just an
damping
injection
now,
here.
or is it gone?
No, no, it's gone. Okay, now please give me the 50 balloon.
This is going to be a fast case. Will be finished very quickly.
Well, when we place the 50 balloon, the most important will be really to place the distal marker of the balloon at the site of the bifurcation, just a little bit proximal, really to optimize the proximal part of the stent.
So here we are with the 50 balloon, and as Jean just said, this is very important that we are now exactly at the bifurcation with the marker. So please do a little contrast, please. I think we can move a little bit in, yeah. Okay. Now I will do a full injection, please. Do it.
Okay,
Okay, we
this is
can
better.
go even a
yeah.
little bit further. So this is okay, I believe. Open it.
चले आओ क्या कह रहे हो
Okay, 10, 12.
टाइम था
Okay, let's see if it's open. I have to look on the fluoro, it's better. Yeah, okay. I see, it's open. Can go down. Now I will pull back the stent a little bit, the balloon, sorry. And now we will flare. Okay?
So we all know that now the coronary stent pricing is an issue
Okay, just for us, store the image.
here for a week, and this is
Okay, very nice.
everywhere. So this is similar to what happened in the United States 10 years ago. And now
Now let's have an image again.
the market has grown
दिखा सकते हैं
in the US.
अगर ये खत्म हो जाएगा
Exactly what's going to happen as well. So join
Let's first have the image now. Okay,
पूछना वो
I will
अगर
push
वो
forward
कर
the
देगा तो फिर
gynae.
दिखा देंगे ये केस खत्म हो जाएगा तो
Okay,
पर इसमें ये लेफ्ट मेन का
now
सेशन
do
है
full injection. Okay.
So few important things to remember.
Yeah, in fluoro. They cannot see otherwise. I'm sorry that you have that bad image, but I will take for me another image as well. Okay, do again.
The second important thing
Okay.
to remember
So what we can see is we see a very nice result.
We don't see it.
I will need to place for the final angio. I will have to place the guiding a little bit better.
Drivers?
The problem we have
Can you put it down?
every time,
Okay.
it's the jail wire.
Yeah, you will find it
Because of the jail wire, you cannot
cannulate.
place your guiding catheter inside the left main. So we think that there is something, a pinch at the ostium of the circumflex, when you see on this
It is.
on this view.
It is.
So maybe what we can do is to place, it's a gain of time, directly a wire in the circumflex through the struts of the stent.
Yeah.
And you can
Can I have another
remove the
wire?
gel wire, and then at that time you can have a good angiography with the two wires in the right lumen.
Exactly. Exactly. This is the plan, Joe.
Okay, we follow you.
So I'll show you the case and I'll make a few important points.
Okay. So I take another wire, and with this wire, we are planning to rewire the circumflex.
Same
I
wire?
try to have enough tip to be able to recross. It's a normal BMW or what is it? It's a BMW.
Okay, same wire.
So let's see.
Any question from the panel?
I just want to emphasize, I think, the importance of obtaining the right view for the left main implantation. I think one needs to just spend a lot of time making sure you've got the optimal imaging. I think the positioning of the osteal stent is very important.
So what we do now is I try to move into the LAD, and now by pulling back the wire, I try to drop into the circumflex. So here I'm in the LAD, and now I try to drop into the circumflex, which should, in theory, give me the most distal entry. So I feel we are correct here, but
Medical treatment is an option, but it almost never works.
we are outside somehow. Let me try again.
And there are two alternatives to endovascular therapies in this case. Either you do complete revascularization on both sides, or you can revascularize one side and then give patients a fem-fem bypass job, which is a relatively low-risk surgery. And once you have the iliac revascularization, you will also have a femoral access to do a cornea intervention.
What is the general consensus? A hydrophilic wire would be superior in recrossing into the side branch or no?
The access I already mentioned.
Williams?
Exactly. So we have a run through here
Our experience is also with hydrophilic
in
wire
case
to
we do not
recross.
make it.
I would often remove the jailed wire at this point because I think you can keep it, but I don't think the circumflex is going to be particularly straightened by that wire.
Very good.
And I think you could remove the jailed wire now and engage the guide.
Yeah, very good comment. Could be possible, yes. Okay, now which is the wire that I can pull? This one, okay. Okay, so what we are trying now is to engage the guiding properly. Yeah, much better. And let's have an angio now. But I will have to do in fluoro. Please store fluoro, yeah? Okay. Okay, I think it's much better. They don't see. Can we do again? Oh, restore the fluoro, the last fluoro? Or we do again? Okay. Go? Now. Okay, that's it.
Give some nitro.
Oh, yeah, we can give some nitro.
Give some nitro. Nitro give 200.
As you can
200.
do also, it's to move in the LAO caudal, in the spider view, and sometimes we have a better view of the ostium or the circumflex. But already in this view,
Go to the LAO caudal, please.
it seems to have a significant narrowing.
Okay. Okay, we do store fluoro again, yeah? Okay, inject.
Yeah. So just a question for all the panel. At that time, the result in the left main is good. You place a 4 millimeter stent, post-dilate with a 5 millimeter balloon. Now we have this result with this image at the origin of the circumflex. What to do? FFR, something, a balloon, or what do you think? That's a question for me.
I mean, the left main LED stent is well opposed. There is symmetry flow down the circumflex. There are no ECG changes, no chest pain.
3.5.
One option would be to just say, stop here. Or if you wanted to do a final kissing, just to open the struts towards the circumflex and end there. I probably would not IVUS and would not do an FFR, because we know that the majority of patients with more than 70%, 3/4 of them have insignificant FFR. So
Second
we'll
inflated.
probably end here.
Everybody agree?
Yeah, I think most of us,
No
we
FFR?
FFR, these moderate lesions, they are all negative. So I would just leave it alone, not even kiss it.
So you have the same opinion. So everybody
Leave it
agree
alone.
on no
I-
FFR in this particular case?
Yes, no FFR probably, yes, but I disagree with the kissing balloon. But if you are not intending to stent the circumflex, which chances are unlikely, I would be very concerned about doing a kissing balloon in the left main.
So in this particular case, what will we do?
I probably will not do anything. I'll just leave it.
Rather in-
I won't do it.
I will accept this result.
It's interesting.
Very much acceptable.
In the room, who we will leave after that? Accept the result and we say at the end of the procedure.
Most of
many
the people
people?
will leave it alone.
And who will do something else? Balloon or additional stent? It's close 50-50. It's difficult to see.
How about,
Julio and Irmat, yes.
how about just opening the strut, going to the circumflex, just the strut, and not get the balloon deep in?
Divergence of
Single balloon, no case.
Open.
Single balloon, no case. Inside the circumflex.
I don't like.
Yes, just the strut.
And you finish by the balloon in the main branch?
No.
Like one side port or?
I think if you take two balloons, we are going to have two oval floating into the left main, which is not a nice thing.
Okay.
So if you do a case, we must end up with
Now
a
the
post
final
part
pot, right?
kind of thing, you know.
Other comment?
Well,
Now can you
I think-
take it out?
I'm the only one who would do a kissing inflation, but I agree with Christophe. I would do a kissing inflation in the circumflex.
Okay, Christophe, what do you plan now?
If I want to
So
give
I
balloon in
already
the
did,
LCX,
so maybe we can go back
then I
and show
shall
you.
have to do kiss.
Can we go back? Can you show them what we did? Okay. Can somebody show them the
We
fluoro?
cannot see the images. We can see you, but not the screen.
Okay.
no?
John, what would
Yeah,
you
now.
do?
Okay,
And now we have the
perfect.
fluoro. Okay. Next, please. Next, please. So, this is what we did. I did a kissing because in these big vessels I feel better. I don't say I have any evidence, but I have no evidence against. So I feel better in the big vessels. Sorry for that.
So typical that they keep on being followed up as a case of hypertension.
Okay. And now we will do the final pot with the 5-0. And if you wish, we could check the result with an IVUS at the end in order to see if we were all right. I personally would trust the result.
I think it should be interesting. We have time, and it should be interesting to,
Okay.
assess the angiographic result by IVUS. It should be nice.
What would you have done in this case, Dr. Fajade?
Yeah, okay.
What would you
What would
do?
you have done yourself?
Can you show me the injection?
We'll wait until the end.
Okay, we go a little bit further.
If you do a
Now
kiss
film.
here, if you do a kiss here, you certainly believe that that circumflex ostium is pinched significantly. So your intention is to dilate
much?
the struts.
Then,
So
yeah.
why don't you do an IVUS or OCT pullback from LAD into left main and from circumflex into left main to demonstrate
Okay, now
whether
take an
circumflex
IVUS,
is
yeah?
significantly pinched and decide whether you need to put a stent or not.
They want to see an IVUS.
Yeah, good comment.
Oh, so somebody pulled. Okay, it's still in there.
We now plan to do the IVUS.
Okay, we are still there. Okay. Can you take it out? Okay. So very good. Now we do the IVUS. Yeah, I think we are fine. We just did the pot. I mean, not so much contrast. It's fine. Okay, we have a Boston IVUS, I think.
Christoph, can you do an angiogram just before you do IVUS? Let's have a look at the os of the circumflex, please.
Okay, yes, we can. I have to do it with fluoro. Can you do the angio, please? Okay. Okay, stop fluoro, please.
Didn't make any difference.
If I'm very honest, my side branch opening did not change much of the image, right?
Yes.
Yeah, absolutely right.
But we have great flow, so I will do nothing further if the opposition is good now.
So, Christophe, we will have a comment from Giulio now.
No, it's not a comment. I'm interested to ask, to vote, who is thinking that the angio was a change, who is thinking that the angio is absolutely the same.
Okay, who feels it is the same?
It's the same.
In terms of pinching, yeah? Who feels something has changed for the better?
Minimum number.
And for the worse?
There are some.
Few. Yeah.
Please pardon my ignorance, but in case we were going to open an IVUS anyway, why not do it in the first place when we had a difference of opinion, before you did a kiss on the circumflex? So if you plan to do an IVUS anyway...
Well, I would not have used an IVUS in this case.
But if you had planning to do it as you did now, would it not have been better to do it before you did the kiss? And the third time I ask you this question, Dr. Fajade, what would you have done?
I will give you my method and my strategy at the end of the case. I don't want to disturb the procedure.
So, Chris, to give you a feel of, what most of the people in the audience think here, the colleagues feel that the decision to do the kiss or not cannot be taken solely on the basis of the angiogram. Majority would feel that you need actually IVUS, and if you don't do it, then better leave it as it was.
High pressure with.
May I ask a question? Christoph, you planning to do the IVUS on the LAD wire or the circumflex wire?
LAD wire. I just want to see, for me, the most important point now is, do we have a good opposition in the LAD? This is the most important question that I have. Can you follow up?
Would you do it in the circumflex too then?
If we have time, we can do. Okay. Are we okay with this? Can we see an image? And maybe you put the IVUS on the screen so that we see.
Yes, Mitch?
So I wonder if anyone thinks that FFR in the circumflex would be helpful or reassuring, since post-dilatation the angiogram looks the same. Would it be reassuring to at least see an FFR that was normal and leave it alone?
Yeah, this was sort of discussed before you came in. Most colleagues felt that, those FFRs, when you measure it with these images, will end up with a normal preserved value anyhow. So questioning perhaps its usefulness.
Okay, now you pull back. Okay, pull back.
Pull back automatic.
May I ask a question? Hello?
Now we do the pullback.
In case a balloon dilatation is felt necessary, how does a sequential dilatation compare to a kissing balloon dilatation? Sequential means first LCX and then the LMCA to LAD dilatation.
Okay, we can address that afterwards, maybe.
Yeah, it's a pot side port versus kissing balloon, and but when we are doing kissing, usually we finish by the final port.
Is it moving?
It's the way to do, But honestly, we have not data to support that. So can you comment IVUS?
Can I do a manual pullback maybe?
Yeah.
Yeah, at the moment the pullback is somehow not running. Now it goes.
Slower kar lo. Please push.
But we are now very distal. Huh?
Yeah.
Okay, I help it a little bit.
After the post trial, and platinum, it's 90% platinum, 10% iridium. Iridium strength.
I'm doing a manual pullback here since something is... Here we are on the stand. I think we have a good position here. Julio needs to comment on that.
For the circle.
And we're even a little bit outside. We are a little bit outside the ostium.
Did not see the circumflex.
So can you show it again? Okay, I hope you can see it. Julie, you want to comment?
Okay, I will try. We are distally, some calcification. We are outside the stent. Now coming back, the stent is starting in a second now. Is almost full of pose. Some doubts about 8 o'clock. Here there is one branch. Now we are coming back. This is probably the ostium of the circ. The images I was saying before, they are quite difficult to be extrapolated to the other vessel. That was the previous question. Why not to scan from the circ now that you have dilated? Because it's telling you much more about not only the ostium of the circ, but even eventually some other position.
I can. Let's check. I think we still have 5 minutes.
One, two,
but none of them had a redilation. They quoted an incidence of aneurysm to be 6%, which is exactly...
I'm on the circ wire, trying to move it forward. I'm fighting always with the Y adapter here.
We have another data which is from Europe, that is the Consortium of Congenital Heart Disease Society. There they use multiple types of stents, starting from Mega LD, the Maxi LD, the CP stents also. However, the CP stent use was restricted to only 14%.
Thank you. Now we will go into the... Can you follow? Yeah. In the circumflex. Can you follow, please?
We know.
The covered stent grafts are much more expensive, and that's not a balloon.
Can you show me the live image?
Can you go a little bit more distally? Just a little bit more.
Yeah, at the moment I don't see an image. I'm trying to get the image back.
It's okay. It's okay.
Okay, do we see?
No, not too
now we see, Giulio. I do a manual pullback again. Can you go with the camera on the IVUS? Okay, show them. So now we are distal, Giulio.
Yes.
And I pull back here.
Okay, this is
some disease.
the branch. Yes, from noon to 6. The other part of the vessel is empty from pathology, and now is coming very close. Now you can see that they are small. There is a little bit of a small ostium. And my suggestion, Chris, if you can go back manually at the point of bifurcation and then inject a little bit of contrast, when you are flashing, we can have much better images of this bifurcation point. So manually going back with the imaging element at the point of the bifurcation and then inject a little bit of contrast. So go live now. Don't do the pullback, go live with the manual. Here is the branch. This is the previous record the pullback. We would like to have you live.
Yeah, can you show me the live image, please? The live image, please. And the pullback needs to...
Okay, take out the pullback, place your image element immediately after the bifurcation.
Okay. I need to see the live image. We currently have no live image. Okay. Okay, I go to the bifurcation, Giulio.
Yes, coming back. When you start seeing the stance, you have a number 8 imaging. Back a little. Okay, now you can see. Okay, a little bit distally, 0.5 millimeter, and then you are injecting. Stop this way, and then you are injecting contrast to show the transition. No. Okay, go back one. Go back a little bit more.
We inject contrast here.
No, but go back a little, just a little bit back where you was at the point of the bifurcation. There are connecting problem with the catheter.
Yeah, I have no live image, unfortunately.
I know. Okay, that's it. If you
now, can I have the live image, please? I need the live image, please. Can you take care for this connection?
It seems that it's much quicker to do left main than to do in imaging afterwards.
Exactly, Giulio. That's the reason. That's another good point.
Well, but we can ameliorate for sure.
I do not see any image, please.
There are
Can somebody
connecting
take care for
problem
the
between the catheter and the PIU.
Okay. Do we see it now? Now, please take care that this stays like this. No. Sorry, Giulio. I have really problems. We lose the connection. I think what we saw is we don't have a significant stenosis. You agree on that, Giulio?
So what I've learned that even with IVUS, we need some contrast, Giulio.
Okay. I would love to do the final image now, and then see. Okay, I will do angio, and then I will give you. Okay. Okay, fluor. Yeah, I'm in fluor. Yeah, inject. Yeah. Okay. Okay.
That's good result.
I think we saw no significant stenosis. I hope you are fine with the result. Yeah, just stop it here and show that. Yeah, you see there's no significant stenosis, Giulio. Are we okay with that?
Yeah, absolutely. Very good, excellent.
Okay.
So thank you,
okay, thank you very
Christophe.
much,
Thank
because
you.
the IVUS is out. Yeah.
It was
Thank you
very nice
much.
demonstration of the
final shot.
Really interesting left main disease and quite
Final
difficult. And I think we learn a lot of technical points in this particular demonstration. And Sam Matthew will summarize the learning point of this session. Thank you, Christophe, and all the team.